was quite funny. We did a health assessment following this, where the students would come in and introduce themselves to the mock patient. And every single one of those students started off with their kia ora, my name is, what is your name, how do you pronounce it, do you have any cultural needs you would like me to consider?
My name's Dr Lynne McKinlay, and I'm here with the final episode of our Headliners podcast series. Today I'm joined by Kiri Hunter, a bicultural New Zealander of Indigenous Maori and Northern European descent. Kiri has an extensive nursing background, having worked across healthcare and academic settings in both Aotearoa, New Zealand and Australia. During the most recent decade, Kiri has been, in her words, growing new nurses in New Zealand, with specialty teaching areas including adult biophysical health, kawa whakaruruhau, or cultural safety, which is the topic we're going to be talking about today, and the Treaty of Waitangi, New Zealand's first immigration and founding document. Kiri's past research focused on new graduate nurses' professional socialisation in the clinical space, including their clinical teaching and learning experiences. Another study explored Indigenous Maori nurses' experience of embedding both clinical and cultural priorities across healthcare settings. Kiri is currently undertaking her PhD, and her research explores New Zealand police responses to and interactions with Maori experiencing mental distress. Kiri, it's wonderful to have you with me today for this podcast.
Tēnā koe. Ngā mihi nui kia koe, Lynn. Absolute pleasure to be here with you today and share this conversation about a topic that is very dear to my heart. So thank you.
It's really great to be with you, and I think this conversation will be of real interest to our listeners today. I started reading a little bit about cultural safety. I think in the Maori language, kawa whakaruruhau. I don't know if I got that pronunciation anywhere close to right.
Sounds pretty good, Lynn.
Not too bad.
Not too bad.
What I understand that it was originally kind of this idea was formulated at a nursing education leadership conference in New Zealand in 1989. And at that time, from my reading, it was difficult to recruit and retain Maori nurses. And recognition of the link between culture and health outcomes, particularly health disadvantage experienced by Maori people, was really critical. And that led to this powerful concept of cultural safety. So I was really interested to talk with you about what your understanding, you're obviously a deep expert in this area, and the fact that this is really growing in its application and its reach across the world at the moment from my reading.
Absolutely is. I think firstly, before I even speak about cultural safety, I really have to acknowledge Dr Irihāpiti Ramsden, who was basically the creator of, she actually led this notion of cultural safety in Aotearoa, New Zealand. And so the late Irihāpiti Ramsden and her whānau, I acknowledge her today. For me, being an educator in the nursing field, I have the task of honouring Irihāpiti and her work, and it's certainly a task. The mahi, the work, is something that I do take very seriously, and I want to honour as accurately as possible in the education of new nurses here in New Zealand. So just an acknowledgement there first. So 1989, as you mentioned, Lynn, was the beginning of this cultural safety concept. And yes, it has spread internationally. You can see, as you do literature searches and across the globe, cultural safety is well revered. Yes, it began in response to the retention, or the poor retention and recruitment of Māori nurses. Also to acknowledge the high levels of deprivation amongst our Indigenous Māori population, and the fact that health professionals, in particular nurses, were not being taught anything at all about Māori culture and how, we've become this hugely biomedical focused model, a monocultural dominant society. through the process of colonisation, and there was a great need to address this the inequities in health that were apparent then, and I'm very sad to say are still hugely apparent today. So over 30 years later, we still are in the position of having not really progressed at all with regards to our recruitment and retention of Māori nurses, as well as the health of Māori. Our health outcomes remain way below that of non-Māori. So back to the basis of your question was about cultural safety and its popularity worldwide.
And its importance, really.
And its importance, yeah.
I was just thinking, it seems to me that when you start looking at the literature, particularly in countries that have got that vulnerable, disadvantaged First Nations people, including in Australia, where we suffer similar, our First Nations people are suffering similarly, but also places like Canada and the US, that's where the literature has sort of started to grow. But it seems to me that it's a much broader concept than even the Indigenous people's health agenda.
That's correct. Yes. No, it really did start. It started off as kawa whakaruruhau, which is at the very essence of cultural safety, was as an Indigenous-led approach, really demanding that individuals and organisations at that organisational level reflect and act around issues of power and privilege. And I think that's where it does strike a chord internationally. So it started off with Maori at the very centre, and then it grew to an umbrella term, cultural safety, whereby it encompasses people who are of different religions, gender, diversity, and so on. Like, it just became a big umbrella term for anybody with any difference in culture other than yourself.
Yeah, that's what really struck me when I started reading it. I suppose when I first started being interested in this, I thought that it was a sort of an extension of cultural competence or cultural knowledge, but it's really much, much more than that, isn't it? It's really about awareness of my culture and the difference between my culture and the culture of the person that I'm caring for in the healthcare setting.
Yeah, absolutely. It is an extension. And, the term cultural safety, it came about as more of a wake-up call, I suppose. It's more of a challenging term that actually you need to act on it. So, acknowledging that culture is a really useful framework to understand people's unique needs, but then to actually act on it. And way back before all of that, it's asking people to look deep inside themselves and look at our own positions of power. It's asking people to respect people of difference.
Whatever that difference is.
Whatever that difference is.
Kiri, I was you mentioned the phrase. Now I have practiced this a few times. The te kawa whakaruruhau, which my understanding means a safe place made from principles. I'm just really interested in that term. Like, this idea of a safe place really resonates with me. It seems it's got a lovely visual to it. That this is a place where people who are different to me can feel safe with me. Where does that term sort of come from?
As far as I am aware, that was the term coined back in the late 1980s by Irihapati Ramsden. I may well be wrong, and it's probably existed for some time way before then, but it's actually come together. It does mean cultural safety, kawa meaning the practices, the customs, so the doing side of things, and then the whakaruruhau is the protection side. So it's a beautiful term in that it means somewhere safe, like a safe place to be, a culturally safe nest or protective space. So in a lot of our nursing programs, we'll have a kawa whakaruruhau committee, and that is led by Indigenous Māori, and it is a place where our Māori nursing students can come, and it is, that protective space where they can share anything they want to and know that it is a safe space to be in. So, yeah. And on the other, it's quite interesting, the term for Māori, our te reo Māori language, it does not translate neatly into English, which in your research, Lynne, you've probably discovered. So the term kawa actually, it does mean sort of the practice of the protocols, or we'd call it tikanga. It also means bitter or sour, which I find quite interesting, in that somebody whose cultural safety's been impinged, it might be the feeling that they feel.
So interesting looking at that language piece, and the words are so important, aren't they? The words are so important for people to feel safe too, as well as the actions. Yeah.
Absolutely. Yeah.
In my reading and exploring of cultural safety, what I came to believe, really, or to think about, I suppose, is that it's not only about patient safety and health equity, it's also healthcare worker safety at work. I'd be interested in what you think about cultural safety as a factor in workplace health and safety.
I agree. And I think in that sense, for ourselves as health professionals, going into spaces where we don't feel safe, our cultural needs are threatened or are affected, and that affects us deeply in a more kind of moralistic or a spiritual sense, and especially when we're talking about retention in our health professional arena. Many of us will simply walk away from a job if we feel morally distressed, spiritually distressed, emotionally distressed. So it's got to be a good fit and a safe place. And I do talk to my students about that as well. And I do think cultural safety affects the worker as well. Part of my research with the Māori nurses in clinical practice, across clinical practice areas throughout Aotearoa, New Zealand, this notion of them not feeling, especially as advocates for the cultural safety of their Māori patients, and they're working very hard, and they recognise the needs of Māori, the cultural preferences, cultural practices, and they're working really hard to honour those practices for their patients and to have those cultural needs minimised, superseded by, what we say, the physical needs, the tasks that need to be done in those practice areas can be quite distressing for the worker.
There's moral distress, isn't there, for the worker when what they want to do, what they want to deliver, and how they want to deliver that to their patients is in conflict with what they're kind of allowed to do or expected to do.
That's correct. And a lot, I did find that in areas of mental health and also our Māori health provider services, which are services for Māori by Māori, the Māori nurses there are able to practice, and they meet the cultural needs not only of their patients but of their own, and they grow themselves, so which is just so heartening. Whereas there are practice areas that they're pushed aside, despite the need for New Zealand registered nurses to be culturally competent. We still see a lot of pockets of areas where they're not honouring that.
Well, it's more than just ticking the box of having done the cultural competence training, isn't it? It's much more from the heart.
It is.
I was reading some papers from the King's Fund in the UK. I don't know if you've read any of their papers, there was some work that they're doing on equity, health equity around poverty and other sort of topics. But I was interested that they are using this 3A kind of model of awareness, action, advocacy. And you've mentioned a couple of times about action, because I think this idea of, a lot of cultural training seems to be about awareness, but it's taking that next step, isn't it, to take action and then also to be an advocate.
Absolutely. And we talk about equity. You just mentioned equity as well, haven't you? I would say to my students, when I'm trying to illustrate action, we're going to be going and spending more time with people who are like ourselves. We have a host of patients and whānau families to care for. We naturally gravitate towards the people that we get on well with and we have a joke with, and they're really easy to manage because we talk the same language. And so studies have shown that this is what happens. We're less likely to go down the hallway and spend time with people who are a little bit different from us, who, they may have different customs that are going on in the room, or different foods that, we're not used to, or it's foreign to the nurse. And so we spend the least amount of time with those folk, and therefore it means that they get less interventions, they get less referrals, they stay in hospital shorter time, and they have worse health outcomes as a result.
And in some papers I've read, things like less pain management. Is that something that you see as well? Less offering of pain relief or other
absolutely.
sort of
the statistics show quite clearly less pain relief, less medications are offered or prescribed. Absolutely.
We've got a long way to go, haven't we?
We
so
do.
One of the actions then, because I was thinking of for our listeners who are I guess I hope our listeners are a little bit intrigued by this topic, and will think, well, what are some things that I can do? Obviously, awareness and just being open to some new ideas is something. But in terms of actions that people can take, so you're suggesting one action might be to deliberately try to spend more time with the people who are maybe I feel a little bit different to me, or maybe just a little bit less comfortable with. That might be one action I could take. Have you got any other sort of suggestions for people?
Oh, many. Actually,
glad I asked.
We had a group of students, because I actually teach pre-nursing registration course as well, so entry level, just a couple of weeks ago in class, a group of level 4 students, and I've said to them, you don't have to know everything, but how are you going to know what somebody's cultural needs are? And I posed this to them, and I asked them to think about what you're going to say, because it is about the questions you're going to ask people, and really just to think hard about, how am I going to know? How will I know? Do I, just look at them and assume that what their needs are? Of course not. So they come up with a question, and it might be something like, do you have any cultural needs you would like me to consider? And it just really is an open question that just can be answered yes or no, or it can be a gateway to somebody saying, actually, yes, I want to have my whānau or my family here all the time. I want them to stay overnight. And it might not come from the patient themselves. It might come from the auntie, but giving people that opportunity to say, actually, these things are important to me and to us as a family, that we can have you on board as our nurse, as our healthcare professional, and then we can be on the same page, because it may take some advocating or advocacy on the part of the health professional to ensure that these needs are met. So as simple as saying, do you have any cultural needs you would like me to consider? And then it's putting themselves in the position where you're not the expert. These people, our clients, our patients and their families, they are the experts in their care. So, and it was quite funny. We did a health assessment following this, where the students would come in and introduce themselves to the mock patient. And every single one of those students started off with their kia ora, my name is, what is your name, how do you pronounce it, do you have any cultural needs you would like me to consider? And I
well done, Kiri.
It wasn't one of the marking criteria at all, but it made me smile, because I thought, what a poignant lesson to have learnt at this very, very early stage of a health professional career, and hopefully going forward that is reinforced along the way. I had
and sorry, I didn't mean to interrupt you, but the question that came before, it's important too, isn't it? How do you pronounce your name? And that's a real sign of respect, isn't it, to actually ask that question?
Well, I say, because they might think, oh, why is it important? But actually, it's just as important, if not more important, than asking somebody, do you have any allergies? But in these lovely conversations with our students, again, more recently, a student who'd recently immigrated from South Africa, and as we were weaving our way through the class content, she said, oh, I would never, ever, ever have thought about cultural difference if not for this conversation.
It's really interesting to me that when you start to think about it, and you might begin from a place of, how will I ask my patient who's a First Nations person or a person from another culture ethnically, how will I ask them? But then it's much broader too, isn't it? Because it might be about somebody who's got a different way of viewing their own gender, or somebody who's got a different family structure to me, or a different approach to work even, or a different approach to living that is so different to mine that it's uncomfortable almost. Builds up that sort of bias in me, and I may not even be aware of that.
Yeah, absolutely. And touching on the unconscious biases that each and every one of us, whether we like to admit it or not, actually carry with us.
When I was talking to you earlier when we were setting this up, you said a really interesting thing, Kiri, and I've actually quoted it since when I was talking to someone else. You were talking about this idea that we've all got and that unconscious bias in us, and we have to kind of reach deep inside and tell it to shush so that we can do our work effectively. I have this kind of mental image of reaching into the back of my brain somehow and telling that little voice to be quiet.
I know, in actual fact, I found myself, like, I'm not by no means, virtuous and pure. I found myself teaching a class of international qualified nurses, Indian and Filipino nurses who were wanting to become New Zealand registered nurses. And in that class group, there was a New Zealand European nurse. And I unconsciously found myself speaking to the New Zealand European nurse more than the rest of the group. And I really, because it was easy, because I knew that she understood me, and I caught myself, as the day progressed, I actually realized that what I was doing, and I was giving her my attention and prioritizing my engagement with her over the others. And I thought, there it is. I caught myself.
But being open to being aware of the fact that there was a risk there for you, as for any of us.
Yeah,
that openness to the idea.
That's right, that it was happening, and that I needed to not do that. So make the extra effort. Yeah.
It's a human thing that we want to gravitate towards people who are like us, who think like us, who look like us. And yet there's so much richness and so much importance in and being able to see beyond that.
Yes.
I was just thinking back to your advice or your wisdom in terms of concrete actions that people can take if they want to be more culturally aware and I guess create better cultural safety for their patients, whether they're doctors or nurses or, hospital managers, I suppose, health service managers. It seems to me it's a little bit like the patient safety movement has this question, where you say to people, what matters to you? This idea that understanding what matters to people helps you to create healthcare that's more relevant and, more tailored to their needs. So I guess you've given us a couple of ideas already. One is about, I guess, that idea of deliberately noticing people that might be a bit different to me, and how do I, spend more time to build that familiarity. But also this question about asking people about what matters to them in the sense of culturally. Do you have any cultural needs that I need to consider? Have you got any other sort of, from, you've obviously had a vast experience of teaching this and working with nurses. Have you got any other sort of practical tips for people to take action or indeed to advocate in a way that's culturally appropriate?
I suppose an answer to that question, Lynn, is looking at ourselves. Do we want to just do a mediocre job, or do we want to do a great job? And, most patients will consider that respectful questions about their cultural background and their preferences demonstrate the health professionals' genuine concern and respect for ourselves, for the person. And when we talk about engagement, what do we want? We want good outcomes. We want our patients to attend appointments. We want them, to access. We want equity of access. We want equity of treatment, and we want equity of outcomes. Surely that's what we want.
And we want our patients to, I guess, listen to us and to consider what we want to offer them. They're not going to listen to us if they don't think we're listening to them, right? It's a two-way street.
Yes, absolutely. And it really goes back to, what does it look like if a patient's not engaging with you? Their body language, they're looking at the wall, they're looking out the door, they don't attend. And also having a little twist on that is something that we talk about here. It's so easy for us as health professionals to go, oh, they didn't attend their appointment. So we're placing the blame on the person themselves. And one day I went to a Māori nursing hui, which is a gathering of Māori nurses here in New Zealand. And I forget who it was. And she stood up and she said, instead of DNA, we should be writing DNI. And that stands for did not inspire, that we didn't inspire that person to be there. So,
wow, that's a pretty powerful way of reframing that, isn't it?
Again, it's blame, it's power, but it's providing a service that meets the needs of our people.
That makes the place feel safe, to come back to the English version of that word.
Yes. Yeah. So at the end of the day, it is about providing choice, and we're not the ones, and we have this, as I mentioned, especially in New Zealand, it's become such a monocultural dominant society where if you don't fit in, then you're marginalised and you experience racism, But people really should have the choice to accept a service or not. And they also should have the choice to have alternate services offered that actually reflect their true cultural needs, which I'm hoping is where we're sort of stepping into.
Can I ask you, so I imagine that this podcast will be listened to by health leaders, people who run health clinics and hospitals. well, at least I hope that it will be listened to by some people in those roles, leadership roles. So I was just thinking about what you just said then. Let's say we have a rate of non-attendance by a certain group of patients, whether they be Maori patients in New Zealand or First Nations people in Australia, or a culturally diverse group for whatever reason. How do I untangle whether or not that person's not coming because they don't choose to accept that service, which is their sort of choice, versus I haven't made it safe enough? Is there a way I can untangle those two things, the choice versus the, I guess, rejection of my service that I've offered?
And it's very valid, Lynn, because how do you know what the reason is?
I guess you'd have to ask, but then I suppose it's how do you ask?
Well, in New Zealand, we would hold what we call wānanga or gatherings in a safe space, in an Indigenous Māori space, where people feel that they are able to share and participate in active discussion, and that needs to be led by Māori.
So engaging with the cultural leaders, because in some communities it may be that there's a particular ethnic group or a particular group of people who've moved to that country from another country, that sort of whatever that group may be. So engaging with the community, the leaders to, I guess, try to understand both the cultural needs but also the barriers in the healthcare system.
Yeah, absolutely. And again, it's who's saying it's a problem as well. Who's identifying the problem? Yeah, it's a very. If we knew the
difficult
answer,
topic.
You know,
but if you've got people not attending, the DNIs, as you said, did not inspire them to come, maybe from the point of view of bias, I need to assume that I didn't make it safe enough as the first point.
Oh, look, it might be.
You know what I mean? I'm not sure.
It might be multifactorial. They might not have enough money to buy petrol. They might not own a car. So, it might go right back to access, issues of poverty and
all of the social determinants of health.
Absolutely. Yeah. I'm at home because I'm looking after my grandmother who's unwell, or my children need me. And my family needs are far greater than my individual needs, and I think that's where we've gone towards a more kind of individualistic, universalistic healthcare. In effect, have moved away from the collective realities of Indigenous peoples, where the person is not going to just go and look after themselves. They're going to put whānau, family first.
And when resources are scarce, then prioritise spending those resources differently, whether those resources are time or money or petrol or...
Yeah, and cultural literacy. We don't use the word health. Again, that's placing the blame on the person that their health literacy is low, and that's probably why they don't understand the importance of attending this appointment.
How should we reframe that, Kiri?
I think our understanding of cultural literacy. What are the actual cultural priorities for this person? So you will see here in bringing it back to New Zealand. I'm very conscious of this is, international audience. But here in New Zealand, our non-government organisations, which, as I mentioned earlier, are Māori-led, by Māori and for Māori. Well, not only for Māori, for all people, understand cultural needs. They understand that if you can't just give somebody a pamphlet and say, this explains your ERCP that you're having down in Christchurch next week, we go back, we peel it back, and we understand that this person actually can't read. So we're spending time actually transporting that person to English literacy lessons right at its basis, right back at the grassroots. The need is far greater. at the beginning of our conversation, we spoke about 1989 being the crux of the introduction of cultural safety in nursing education. I remember as a young nursing student in 1991 actually being part of that introduction. And we have to remind ourselves that 30 years isn't a long time.
Not a long time in human history, is it?
It's not really. It's very disappointing, as I mentioned, to not see any improvement in our workforce or our health statistics. And we can't give up. We just have to keep forging forward. And yes, the next generation, hopefully, understanding a lot more about our history, because it has been hidden, so that not only nurses but everyone in New Zealand doesn't continue to blame the victims, which are our Indigenous Maori, of the historical and social processes and for the current plight. Why are Maori impoverished? Why are Maori health statistics so poor? Why are Maori incarceration rates and unemployment rates so high? Oh, we blame them. Well, actually, if you understood the history, you will stop blaming the victims. So, and I say to my students, hopefully one day I won't be able to, I'll be out of a job. I won't have to stand in front of these seas of faces who one or two of them might have some knowledge of our history, and the rest are completely unaware, and they walk out like the scales have been lifted from their eyes, and it's like, wow, really? That went on? So going forward, educated would be my goal, our goal, and all the other Maori nurses and nurse educators that have been working for many years, certainly, and just one of many workers here. We talk about competency, don't we? You mentioned that about it being a tick box exercise.
Well, that's a risk, isn't it?
Oh, for me, it's really, well, who's deeming you competent? You are. You're getting your friend to say, oh, yes, she is, and here's an example of how competent. But if we look back at the true essence of cultural safety, it's the patient who determines whether you're being culturally safe towards them.
Yes, and I think our ability to receive feedback or to look at evidence that we're not being culturally safe and make sense of that without, as you say, without blaming the patient, without saying, well, that patient didn't turn up for the appointment, therefore they're not interested in receiving treatment. Maybe they're just not interested in receiving it the way I offered it.
And there's the bitter, the bitter,
the kawa that's bitter.
The other meaning to the word, isn't it? We don't like to look at ourselves as in a negative light, but maybe a little bit more of that feedback, patient feedback. But again, there's power and power imbalance. Do we want to hand over the power?
Oh, will patients be brave enough to give us the feedback we need?
Exactly. And it's a big ask, isn't it? But but I think just remembering that it is cultural safety really is determined by the patient themselves.
You've given us such a lot to think about today, Kiri. Certainly what I've really heard from you is about the fact that while we're making slow progress in a lot of these health equity, your health equity agenda in New Zealand and mine in Australia, and I'm sure for many of our listeners around the world, they've got their own challenges in this space. Yeah. And I guess what I've heard is the importance of really trying to take some responsibility for the fact that I need to do something differently if I'm going to make it culturally safe for my patients who are different to me. I need to, open up and reach inside and look for those biases that I might hold. But you've also shared, I think, some really concrete quite simple things that individuals can do to begin to become more, I suppose, more self-aware about how I can, choose to behave differently if I want to create that safe space for the patients. So it feels like it feels approachable now, because you've given me a couple of really and hopefully given our listeners a couple of really simple things actually that we can do when we, kind of notice, if you like, here's a patient who's different to me, whether it be, ethnically different or different in another way, to say, well, ask them what's culturally important and things that I might need to consider, and to, be open to the fact that non-engagement in healthcare might be just as much to do with me as to do with them, that I haven't actually given them the healthcare, offered that healthcare in a way that feels safe to them.
I think you've summed it up really well there, Lynn.
Have you got any other sort of, I guess, last minute, ideas or thoughts?
Well, it does. I mean, we always say it goes back to the leadership as well, the leadership and the culture of a place that you work in, and being made okay that you actually advocate on the part of your patients. And if you see a patient who's not getting the care they need, you notice that they're getting more pain relief, or that they're getting preferential treatment over somebody else, then having a safe environment where you can actually talk about that and say, hey, that patient, come on, and that's the team approach. So having an environment that you work in where you can say, hey, you didn't chart the same medications for that patient down there. Why? The space for advocacy. Because, we can do so much ourselves. And I always, I paddle, call them outrigger canoes, we call them waka, in a team, with six women in a team. And we think we just sit in a team and paddle along together, and the outcome's going to be what the team can produce. But in actual fact, and I say to the girls paddling, you make a difference. So that it does need to be definitely at an individual level, but also the organisational leadership level as well. That needs to be looked at.
Kiri, I've learnt so much from listening to you today and for having a conversation with you. It's really been a very rich discussion, and I hope that our listeners have also, been made a bit curious about this, to look in the mirror a little bit and to think about their own part in creating a healthcare place which is safer for their patients, regardless of whether the patients are from different racial or ethnic backgrounds, or different to us in any way at all. Even age, or there's lots and lots of ways in which we differ to our patients. But it's really, I'm really heartened also to learn that there's some practical, relatively simple things that I can do to start on this journey and break it down into something that's achievable for me.
Thank you for having me.
And with that, we reach the end of today's podcast, Cultural Safety, Creating Safe Spaces in Health. I'm not sure about you, but I learned a lot from listening to Kiri Hunter and her experiences in researching, teaching, and advocating for cultural safety. I'd like to take this opportunity to remind our members that you can join us on our next Beating Burnout virtual workshop. These workshops are free of charge for members. Please use the link in the podcast description to register. For more information about medical protection, or if you're already a member and would like a certificate for listening today, please look for details in the description. I've been your host, Lynne McKinlay, and it's been a real delight to share this Headliner series of podcasts with you.